Good evening, everyone. Welcome to the series of webinars from the Department of Emergency Medicine, Yashoda Hospitals. Today's topic is seizures in children. So the speaker for today is Dr. Sagari Gullapalli. She has done her MD Pediatrics and after that went on to adult neurology DM. Then she has a keen interest in epileptology. Then she has done her postdoctoral fellowship in adult and pediatric epilepsy and neuroelectrophysiology. So any seizures are very much frightening to the family members, especially if it's a child, it's even more frightening. So the management in ER is going to be very much crucial, and the attendants will be around you. The way you manage is going to be very much important. So to deal with that, we'll have a discussion from Dr. Sagari Gullapalli, and she's here with us. She'll be joining us in about 10-15 seconds.
Good evening to one and all. I'm Dr. Sagari. I'm here to discuss about the most common presentation to the emergency department, that is pediatric epilepsies, and the most common scenarios in pediatric epilepsies to the emergency department. There are about 5% of children will have a seizure by the time they were around 16 years old. First, whoever presented with the seizure, whether it is a true seizure or pseudo seizure, we have to differentiate by following features, like we have to ask about the onset, duration, nature of movements, tongue bite, eye findings, and details of the recovery phase. What are the main features of when we can consider it as a seizure? These are the following features which has high specificity to consider it as a seizure: lateralized tongue biting, flickering of eyelids, dilated pupils with blank stare, lip smacking, increased heart rate and blood pressure during event, and post episode there is a altered sensorium like post-ictal phase. They will not recover immediately after the episode. These are the features of true seizures. Then what are the seizure mimics? What are seizure mimics are? In the pediatrics, most common seizure mimics are breath holding spells. Breath holding spells will have a clear emotional distress or pain before the episode, and they have emotional upset, crying, pallor, and loss of consciousness. Initially, they will present as a breath holding with loss of consciousness, followed by a seizure activity. Recovery from the breath holding spell is rapid and complete without any post-ictal phase. Then coming to what are the pseudo seizures, when we can consider it is most commonly in adolescent population, and side to side head movements, arm or leg movements with eye closed, side to side head, arm or leg movements with eye closed. Generally, we'll consider these as pseudo seizures, and most common population were adolescents. And another seizure mimic was syncopal episode. How to differentiate between syncope and seizure? First, we have loss of consciousness, followed by a seizure activity like mild twitching episodes, not like strong movements. It's like mild twitching episodes, and there will be a rapid and complete recovery after the episode, immediately after the episode. And coming to seizure types, what are the seizure types? Seizure types are generally two types. Those are focal and focal generalized, and another category was unknown. What is seizure? Generally, when we have to consider according to seizure duration, we can divide into generally seizure will be within 5 minutes. If it's lasting for 5 to 30 minutes, it is called convulsive status. And if it is lasting 30 to 60 minutes, it is called established convulsive status. Longer than 60 minutes, it is called refractory convulsive status. These are the common conditions which will be seen in seizure activity, means common terms in the seizures, common terms in the pediatric epilepsies. Like example, febrile seizures. What is a febrile seizure? Convulsive seizure in a previously healthy child aged between 1 month and 6 years during a febrile illness. Body temperature should be more than 38 degrees. In the absence of a defined central nervous system infection, it is called febrile seizure. This is the most common presentation in the pediatric emergency department. It is around 70% of provoked seizures. Provoked seizures means with a cause, should have an underlying cause. Next, coming into benign convulsion associated with the GE. Convulsive seizure occurring in a previously neurologically healthy child aged between 2 months and 6 years during a non-febrile episode of gastroenteritis. Body temperature is less than 38 degrees without clinical signs of dehydration and or electrolyte disturbance. This is benign convulsion associated with GE. This is having a cause. So this is a provoked seizure. Febrile seizure is also a provoked seizure. It is a common presentation of provoked seizure to the pediatric emergency department. And coming to acute symptomatic seizure, convulsive seizure in a previously neurologically healthy child within 1 week of an identified acute neurological or systemic insult. It is a symptomatic seizure within 1 week of an identified acute neurological or systemic insult. Next, coming to acute on remote symptomatic seizure. Acute on remote symptomatic seizure is a convulsive seizure in a child with a previous known CNS abnormality within 1 week of a new identified acute neurological or systemic insult. In a previously known CNS abnormality, now with a new identified neurological or systemic insult within a 1 week. This is also having a cause. Acute symptomatic seizure and acute on remote symptomatic seizure comes under provoked seizure. Then coming to remote symptomatic seizure. Remote symptomatic seizure is a convulsive seizure in a child with a previously known CNS abnormality occurring more than 1 week after an identified acute neurological or systemic insult. It's like after a week. Before a week, and this is called as acute on remote symptomatic. Then if it is after a week, then it is considered as remote symptomatic seizure and it comes into unprovoked seizure category. What are unprovoked seizures? Seizures occurring in the absence of a potentially responsible clinical condition or beyond the interval estimated for the occurrence of acute symptomatic seizures. This is called unprovoked seizures. What are provoked seizures? Provoked seizures are like whatever we have discussed prior. Febrile seizures have a condition underlying, and benign convulsion associated with gastroenteritis. Acute symptomatic seizure and acute on remote symptomatic seizure. These comes under provoked seizures, which has a cause. And in a pediatric, in a less than 6 months age group, common presentations were hyponatremia, dilutional hyponatremia due to feeding formula changes. Dilutional hyponatremia is also a common presentation, which will be seen in pediatric emergencies below 6 months. It is also a provoked seizure. And coming to what, like already discussed, provoked seizures, 70 to 80% in various series. It includes about 70 to 80% cases, and it is between 6 months to 6 years. And febrile seizures is the most common presentation. And these are the types: acute benign convulsion associated with gastroenteritis, acute symptomatic seizure, acute on remote symptomatic seizure. These are all comes under provoked seizures. In these, most common presentation is febrile seizures. So next, coming to unprovoked seizures, this comes to around 20%, and these were all remote symptomatic seizure, which has presumed idiopathic age-related epilepsy syndromes. Like means in pediatric age groups, most common presentations in pediatric age groups are benign epilepsy syndromes. Benign epilepsy syndromes like either focal epilepsies or generalized epilepsies. Focal epilepsies most common are Rolandic epilepsy or Paniatopolis or benign occipital epilepsies. In generalized epilepsies, most common presentation is childhood absence seizures. The scenarios all childhood absence seizures, generally they'll present with sudden staring episodes with eye blinking lasting few seconds. Immediately they will be normal. They don't have postictal phase. This is one exception. This is called childhood absence seizure. This is one common benign epilepsies. And coming to benign occipital epilepsies, scenarios are Paniatopolis and gastros. This will generally present as like vomiting episodes, prolonged autonomic signs like mydriasis, eyeball dilatation, autonomic signs like tachycardia, more than 30 minutes episode. This and all comes under generally with benign occipital epilepsies like Paniatopolis. These are prolonged episodes, and this have a close mimic with syncopal episodes. So even in a syncopal episode, even though you are very confident in syncopal episode, we have to do one EG in seizure mimics like syncopal. Sometimes benign occipital epilepsies like Paniatopolis will closely mimic with syncopal episodes. And a child presented with one syncope episode means they have sudden fall in the school, and they will come, the child will come to the emergency department. Even though you're very strong in syncope, sometimes, not always, rarely, Paniatopolis, benign epilepsies like Paniatopolis, occipital epilepsy will mimic like syncope. So we have to do one EG. When good EG, they will have very occipital spikes and very classical Paniatopolis EG. And next, coming to unclassified seizure. Next, when a patient comes to emergency department in the first convulsive seizure, what is the first convulsive seizure? What is the first convulsive seizure coming to emergency department? It includes at around 0.4 to 1% of total pediatric emergency visits. And 50% of the total visits for convulsive seizures in that first 50% of total visits for convulsive seizures this is a big dilemma for the physician, and it is a very concerning for the parents. And these were classified as provoked and unprovoked. This is any patient who was presented first convulsive episode to the emergency. And we have already discussed about provoked seizures and unprovoked seizures. And in the first episode, what we have considered in the first who were presented with convulsive into the emergency department, mostly they were generalized. 85% were generalized and focal were 15, and seizure duration was shorter than 5 minutes in almost most of the patients, like 75 patients, and only 5% have ongoing seizures on the arrival. And febrile seizures are the most common presentation in that. 70% all febrile seizures, and those are provoked. And coming to what is febrile seizure, when to consider it febrile seizures, when a patient comes to, because whoever comes to the emergency department in the pediatric age group, generally with provoked or mostly febrile seizures, it is around 70%. So we have to know detailedly about simple febrile seizures and when to evaluate those things and all. And coming to simple febrile seizures, most common seizure is generalized. So whoever presented the emergency department with the fever of more than 38 degrees and should be generalized tonic-clonic and it should be less duration, less than 15 minutes, and only one episode within 24-hour period, we have to consider it as simple febrile seizure, and they will be recovered immediately. They will not have prolonged post-episode phase. They will be recovered immediately. These type of features we have to consider it as simple febrile seizures and simple febrile. Next, coming to complex febrile seizures. These are only 20% to the febrile seizures, and this is focal onset, unlike generalized in simple febrile, and this is prolonged more than 15 minutes, unlike simple febrile. And this will have these episodes will be recurred in 24 hours, and and they will have a prolonged phase of post recovery, means they will be longer, they will be altered and drowsy and all, and they will have sometimes Todd's palsy. Whether we have to evaluate simple febrile seizure? No, not required every time. routine, just fever workup is fine. And only one exception is like age younger than 18 months, even though he's a simple febrile seizure, we have to do LP according to AAP guidelines. Otherwise, it's not required to do LP for a simple febrile seizure presentation. Next, coming to any patient who was presented with the complex febrile seizure or provoked seizure, sorry, unprovoked seizure, means without any underlying cause, should be evaluated. In the unprovoked seizure in pediatrics, most common presentations to the emergency department are benign epilepsies. Benign epilepsies should be we have to evaluate for the benign epilepsies thoroughly, because benign epilepsies, they will improve with the age. And in complex febrile seizures and unprovoked seizure, we have to evaluate thoroughly the patient. We have to examine the patient. We have to see about the neurocutaneous markers, and we have to see a head, bulging fontanelle, microcephaly, dysmorphic features, any trauma history, any VP shunt, any examination. We have to do eye examination like papilledema and retinal hemorrhages, and neck and hepatosplenomegaly. We have to look for any focal neurological deficits, any persistent headache, any persistent alteration of consciousness. And we have to do investigations like blood routines in complex febrile or unprovoked seizure, and CRP, all blood investigations, electrolytes, and meningitis workup. And in a pediatric age group, a rotavirus antigen, some studies says we have to send stool rotavirus antigen. And coming to when we have to do EEG, in simple febrile seizure, it is definitely not required. In a complex febrile seizures, we have to consider it. In an unprovoked seizure, definitely we have to do to differentiate between whether it is a benign epilepsies or epilepsy syndromes, epilepsy encephalopathies. In a benign epilepsies, definitely we can reassure the patient that it will go with the age. And what is the EEG criteria when we have to do EEG? Always better to do a good prolonged EEG, like 8 hours to 6 hours. Always, as an epileptologist, we used to consider it as 6 to 8 hours with the proper guidelines of 3 hours sleep, 3 hours awake, and with the good other hyperventilation measures and all. These are all required for a proper diagnosis of a syndrome, whether it is a syndrome or some other epilepsy encephalopathies. And coming to when we have to consider neuroimaging in an epilepsy patient, if it is a focal epilepsy or any abnormal neurological examination, age younger than 2 years, even though if it is younger than 2 years, even though it is a simple febrile seizures, if it is younger than 2 years, means around 1.5 to 2 years, we have to consider LP and neuroimaging. Characteristics of a symptomatic generalized epilepsy syndrome, like infantile spasm, any characteristic symptomatic epilepsy, any failure to control worsening of seizures, changes in seizure manifestations or developmental regression, any new onset of seizures, epilepsy presenting with evidence of a medical emergency such as increased intracranial pressure or status epilepticus. And here I want to share one more common presentation in the pediatrics, sir. Hydrocephalus pediatric patients will present like close mimicker seizure activity, but they will present like as a posturing. It's not a seizure. Any patient who was presented with hydrocephalus with any patient who was presented with the posturing, it will closely mimic a seizure, but it is not. It's a seizure. It is not a seizure. It's due to coning in hydrocephalus. This is also one common pediatric emergency presentation. This is a mimicker for the seizure. This is also one common mimicker. And coming to another where to consider the imaging, VP shunt neurocutaneous disorder, travel to an area endemic for cysticercosis, immunocompromised patients, hypercoagulable states like sickle cell disease, and bleeding disorders. Risk of recurrence. When this is very important to the emergency physicians, because this has to be like while counseling, this will help you. This will help the emergency physicians to assure the patient about the future and all. So overall recurrence of 4 years was 79% for provoked seizures and 60% for unprovoked seizures. Unprovoked nature of the first seizure has a risk itself, has a risk for this risk of has a risk for recurrence, and multiple seizures in the first 24 hours, and positive family history of a febrile seizure or epilepsy, any pre-existing neurological conditions, any abnormal EG. What are the recent trends in the simple febrile seizures? And recently, because of like the lumbar punctures has come down from 11 to 0.6%, and head CTs has come down, which is a good thing. All were following the guidelines, and hospital admissions from 19 to 5%. Diagnosis of epilepsy. What is an epilepsy? Two or more seizures within 24 hours, unprovoked seizures. Unprovoked seizures within 24 hours is an epilepsy syndrome. Unprovoked nature of the first seizure was the main predictor of later in epilepsy. And only 2.5% with provoked seizures. Only 2.5%. It's very less. And age older than 6 years, and pre-existing neurological conditions, and focal onset of first seizure. And coming to one more common scenario in pediatric emergencies was status, and how to approach a status in pediatric patients. Like first, like adults, it's like same airway, oxygen support, ventilation, and established IV, and same IV glucose and pyridoxine. In pediatrics, pyridoxine should be considered. Pyridoxine responsive seizures are very common in pediatrics, especially in the infancy age group. And coming to first line drugs, benzodiazepine, lorazepam, diazepam, midazolam. And one important thing is here, benzodiazepines can be given intramuscular and intranasal route. They were as efficient as intravenous route benzodiazepine. And these recent studies said both are equally efficient, and because of early, we can give early these other routes, so they can have a seizure they can control seizures as earlier than intravenous route, because for having IV access and all, it will take time. Both were equally efficacious, and if seizure continues for 5 to 15 minutes, we may repeat benzodiazepine for 1 to 2 seconds, and next followed by phenytoin or fosphenytoin. In between those two, in pediatric, fosphenytoin has good studies because of less side effect profile. And in second line drugs, what are the second line drugs? Actually, second lines were phenytoin, fosphenytoin, and Levipil. And phenobarbital is a very good efficacious drug in pediatric epilepsies, which is as efficacious in some studies says it is 2 times more efficacious than phenytoin. So we can consider even phenobarbital as a second line drug immediately after benzodiazepine in pediatric age groups. And coming to valproate, phenytoin, some contraindications for phenytoin and fosphenytoin are in cocaine and toxicities like cocaine and all, some theophylline and all toxicities. Generally, some phenytoin and fosphenytoin will aggravate seizures. We have to consider valproate or phenobarbital. And if seizure continues for more than 30 minutes, we have to reassess the airway and consider intubation. Infusion, same like adults, like pentobarbital, midazolam, propofol, and ketamine. Here I want to mention one more important thing is recent studies like updates of 2022 says ketamine has 48% efficacy in controlling pediatric epilepsy, pediatric status when compared to other drugs. And if seizures continues more than 60 minutes, same intubate and general anesthesia. Thank you for giving me this opportunity. Thank you, Srinath sir and Naveen sir, for giving me this opportunity.
Can I ask if you have any questions?
Anybody has questions? If a baby is given phenatomic, for next seizure, what should be given? The baby is a phenatomic BHC and referred to our hospital. For next seizure, what drug should be given? Phenatomine or Levotil? So obviously we have to, if it is not improving, we can consider, if it is not prior the benzodiazepines once only given, you can consider giving again once benzodiazepine. And we can go with other second line drugs, like based on the scenario, we can go with the second line drugs like Levotil. Phenobarbital, I've already mentioned, like phenobarbital is a good second line drug, which is available in peripheral centers. And Levotil, valproate, based on the scenario. And based on the scenario, generally status will be like two types, focal or generalized status. For generalized status, we'll consider like valproate. If it is a focal status, we will consider like Levipil, Brevipil, or lacosamide. Even lacosamide also we'll consider for a focal status. For a generalized status, better to go with valproate or phenobarbital.
There's one more question.
Yes, sir. Actually, that is another question, sir. I don't have experience of giving. I don't have an experience of giving diazepam IM. We used to give, like, we will generally give like Midas or Midas, any IM and all. We used to give Midas and all. Otherwise, diazepam, I don't have an exposure. Intranasal Midas and all, I also have given. I don't have, but still we can consider giving. But actually, pediatric status and all, diazepam, IEM and all, guidelines wise, I didn't see, like, I don't have any clue in the papers and all, like saying IM has a very good efficacy and all. But what I know about is lorazepam, midazolam, intranasal, IM routes, and those things are even studies says. And even rectal also sometimes says rectal, but that is not efficacy. That is not much efficacy as intranasal. More considered is intranasal route. But IM, I don't have any. I cannot recollect the study saying the IM route is as efficacious as this. No, IM diazepam saying.
We have a couple of.
And if a baby is given phenatomic, oh, the next question. Same. Okay.
Okay, looks like there are no more questions, ma'am. So thank you so much for joining. It's been a wonderful session because finding someone with equal interest in pediatrics, neurology, and epilepsy, we couldn't find a better. Even if we try, we can't get anyone better than this. So you have all those three topics. You have excelled in pediatrics, neurology, and epilepsy. So thank you very much for sparing your time. We'll be ending the session. So if you want to get notified about future sessions, you can subscribe to our Telegram channel. Thank you.